we all face vertigo patients, and I think that it's a very frustrating situation. As an ENT doctor, I feel very frustrated when I face vertigo patient in my clinic. My first slide, I will show you, this is the latest prevalence study about vertigo patients. It was done in Germany, in one of the biggest vertigo centers in Europe, which is in Germany. It was done on 34,860 patients during 5 years of study. They classified their patients according to the International Classification of Vestibular Disorders. They found that the most common cause of vertigo was functional dizziness, which we all face in our clinics. Patients with unreal vertigo, maybe due to psychotic problems or others. The second most common cause is the benign paroxysmal vertigo, the third central vestibular vertigo, fourth vestibular migraine, which I will talk about later. Here I will go back to the International Classification of Vestibular Disorders, which was done in 2012 in Bahrain. Unfortunately, it's not updated till now. It's still the same since 2012. Vertigo, due to this classification, was classified vertigo was classified due to 3 categories. First, they classified vertigo according to the temporal course. Vertigo may be as attacks. These attacks may last from seconds to minutes, such as benign or seasonal vertigo or vestibular paroxysma. These attacks may last from minutes to hours, such as vestibular migraine, such as Meniere disease or other causes. Vertigo may come as acute onset, and then it will last for days and weeks, such as unilateral vestibulopathy or some central cause of vertigo. Vertigo may persist for more than 3 months, and this is maybe due to chronic bilateral vestibulopathy, or maybe due to functional dizziness, which I spoke about, which is due to psychological causes. Another classification of vertigo may be due to precipitating or modulating factors. Many factors may precipitate or aggravate vertigo attacks, such as changes in body position, like benign positional vertigo. It may be provoked by pressure, modulation in the external canal, or loud noises such as third mobile window syndrome. Maybe sometimes vertigo may be aggravated by some emotional stress or sport activities. These are such as functional dizziness. I will begin with migraines vertigo or migraine-associated vertigo. I chose this photo, in fact, because this disease is very common in middle-aged women. As we all know, migraine, and me as a migrainous patient or migraine-suffering patient, is a very debilitating problem. Quickly, I will say that migraine is, as we know, it's a hemisphere headache. It's very like this photo. It's very debilitating, it's very painful, it may affect our quality of life. Okay, migraine-associated vertigo. It's attacks of vertigo which is aggravated by changes in the head position. These attacks may last from 5 minutes to 72 hours or 3 days. But between the attacks, patients are used to be normal. Neuhauser, which is a German professor, Deutschland professor, he was the first to put criteria to define vertigo or migraine-associated vertigo. He divided vertigo, migraine-associated vertigo, into 2 types. The different migraine-associated vertigo, the criteria were we have episodes of vestibular disorder or vestibular symptoms. These episodes were moderate to severe. These episodes are associated with a migrainous headache These episodes are associated with at least one of the migraines associated symptoms such as photophobia, phonophobia, or other migraine symptoms. And we have the other type, which is probable migrainous vertigo, the same, but we have no previous history of migrainous headache. The latest criteria, which was done for migraine-associated vertigo, it was in 2012. According to the International Classification of Vestibular Disorders and International Classification of Headache Disorders, migraine-associated vertigo was also divided into two types: definite and probable. Definite migraine-associated vertigo, we have at least 5 episodes. These episodes, first, we have vestibular symptoms that last from 5 minutes to 72 hours. Second, these symptoms are associated with migrainous headache. These symptoms are associated with at least one of these items: headache, or photophobia, or phonophobia, or visual aura. Finally, this headache or this vertigo is, we exclude other diagnoses. We have no other causes. We have just vertigo. Probable vestibular migraine, the same, but we don't have a previous history of headache. We have just vertigo symptoms, and we have migraine-associated symptoms without headache. Here I just wanted to show you the photos of some pioneers who worked on this topic. The first to talk about migraine-associated vertigo was Robert Slater in 1979. He named it benign recurrent vertigo. Then Robert Gallo in 1994. The real pioneer was Neuhauser in 2001, and he was the first, in fact, to put real criteria to define this item. To talk about the pathophysiology, we have many theories. The peripheral theory, they talk about vasospasm in the liberating artery, or neuropeptide lesion in the inner ear. The central theory was they talk about depression in the vestibular cortex, or the vestibular and nuclei in cerebellum or brainstem. The central theory also talks about surgery or neuropeptide lesion centrally. The third theory, it was about channelopathy, or we have problem in the neurologic synapses in the inner ear or then centrally. Epidemiology, I'm very sorry to postpone this slide till here. I should talk about it early. In fact, vertigo-associated, migraine-associated vertigo is a very common. It's the commonest cause of vertigo in children between 6 to 12 years old. In a study done in the USA in 2020, last year, about the prevalence of migraine-associated vertigo, they found that it affects 2.7% of adults in USA. In Germany, they did the same study in 2020. They found that it affects about 1% of adults. Middle-aged women are considered the most affected population. The German study found that it affects about 5% of middle-aged women, so females are more proposed to be affected. As migraine, this problem is maybe to be transmitted genetically, so it's transmitted by autosomal dominant. Here, quickly, this is the Neuhauser study that was done in 2004. The number of patients were a little, not that much, 33 patients. He studied the symptoms, and he studied duration of the vertigo, and he studied the associated symptoms. Physical examination seems to be normal out of the attacks period. Pay attention. I just put the slide to remind you all that migraine most of cases may cause depression and panic disorders. Migraine associated vertigo may cause the same problem even if headache is not available, is not done. To talk about the treatment of migraine associated vertigo may be challenging because attacks may last from 5 minutes to 72 hours. So before we think about the medicine to use, or before the medicine can think to begin its efficacy, the attack may subside itself. Then these attacks may be very debilitating, and they may affect the patient's quality of life. So patients may ask for a prophylactic treatment. As all vertiginous patients, we should make the patient be convinced that vertigo is not always treated medically. Sometimes we need other choices, such as education or such as physical exercise, or such as vestibular rehabilitation or other choices. As migraine, the main point in migraine is avoidance, and the main point in migraine-associated vertigo is avoidance. Many studies were done about this issue. The same things that may trigger migraine may trigger also vertigo, such as hormonal causes, menstruation, ovulation, such as dietary causes, alcohol consumption, or some kind of cheese, chocolate, psychological causes such as stress, such as anxiety or depression, some drugs such as histamines or antidepressants or other causes. Pharmaceutical treatment. Pharmaceutical treatment can be divided into two wide categories. The first category is the acute treatment. How can I treat the attack? I have multiple choices. The first choice is NSAIDs, such as Brufen, such as diclofenac. It affects migraine headache, but it also shows an efficacy in the vestibular migraine. It helps to subside the vestibular symptoms. Triptans. Triptans are the most common used pharmaceutical agent to treat the acute attacks. In fact, we have 3 kinds of triptans. Rapid, powerful agents such as maxillar, triptan, or moderate or weak or slow. The most common use are the first one, triptan. Sometimes we are obliged to do IV methylprednisolone infusion. In some cases, when attacks may last for more than hours, and when they are very severe. Goat alkaloids, which are used to be the most common used agents in migraine headache, are not advised in migraine-associated vertigo, so it's not used anymore. The preventive treatment, the other category of treatment, the preventive treatment between attacks, we should use the preventive treatment in some cases. First, when the incidence is more than 2 to 3 times per month, so when incidence may affect the patient's quality of life. Then, when the attacks are very severe. Second, when the attacks are severe, so abortive therapy for these attacks is unsuccessful. This preventive treatment may be non-pharmaceutical, dietary manipulation or acupuncture or vestibular rehabilitation. Or this prophylactic treatment may be pharmaceutical. The first and most common used agent is amitriptyline, which is SSRI or tricyclic antidepressant. The other agents are anticonvulsant agents such as topiramate, such as valproic acid, and lamotrigine. Calcium channel blockers are very common used agents in prophylaxis of migraine headache, which shows a very good efficacy in prevention of migraine-associated vertigo. طبعا عائلتي كبيرة، أشكر المواساة، أتشرف بالانتماء وأتشرف بكل حدا موجود بهذه الصورة. البيتا بلاكر هو بيستخدم يستخدم بشكل كثير كبير كعامل بجرعات كثير صغرى كعامل وقائي من تكرار الهجمات الصداع اللي هو صداع الشقيقة. هو يستخدم بنفس الجرعة اللي هي جرعة لا تتجاوز أحيانا بنستخدم 20 عادة الاندرار مشان الوقاية من الفترة. طبعا فترة لا تتجاوز 30 لا 20 اوكي هذا جدول بس هلا الفكرة انه بقول ال 20 تمام. اساس كان في سايد افكتس تبعيته بالدلتا بلاجر.
شكرا جزيلا دكتورة ردينة، المحاضرة الشيقة، الموضوع صعب.